Welcome back to The Short Code, coming to you from the amazing and intense world of med school at the University of Iowa Carver College of Medicine. I'm Dave Etler, and this week, we don't like to talk about death. In this society that we have, we say people have passed away, they've crossed over, they've gone to a better place. Even they've kicked the bucket, bought the farm, or pushed up daisies. We'll say just about anything except the actual word, but we're going to say a lot today, I expect, because it's the subject of our show. And to do that, I'm joined in my comparative rigor mortis, that's a reference to my age, by my very much alive co-hosts like PA2 Chloe Kepros.
Hi, everyone.
M2 Nick Lembazeder is here.
Hello.
M2 Sarah Nichols has joined us for the first time. And M1 Jonah Albrecht
Howdy.
has come back. Thank you for joining me to talk about this somewhat serious issue. I hope we don't get too serious because that makes me uncomfortable.
Oh, no. Thanks for having us, Dave.
Yeah. Chloe, you suggested we do this episode, as I recall, I think.
Yes,
right?
yeah.
Tell me your motivation for wanting to talk about this.
Well, I'm really interested in like hospice and palliative care. And I think that it's interesting because I think there's a lot of we talk about birth a lot, right? Like OBGYN. But I also think that hospice and palliative care, they're two kind of very similar life transitions in some ways. And we don't get a whole lot of time to talk about them in our classes, honestly, which a lot of us have found. So we were kind of thinking about how does that impact our preparedness to talk to patients and family members and feel comfortable with it ourselves, and thought we should talk about the D word. I kind of, in terms of what I brought to talk about, is I had a little bit of a review on the policy for economics of like palliative care and hospice. And that was for a small group that we had actually. So it was talking about health policies. And I was kind of asked to look into it from an economic standpoint. Not all of it focused on that, but just kind of discussing the fact that like patients with chronic and serious illnesses, it's kind of a complex problem, and it does have a significant strain on like healthcare resources, but also on obviously like the family and patients, their quality of life. There's a lot that comes before the actual like process and like end result of death actually. Mm-hmm. And with palliative care, it's something that we've had a little bit of time to discuss in classes, but the idea that we're helping patients through the whole process of dying, which yes, it ends in death, but there's a lot more to it than that end. And being able to alleviate pain and kind of optimize quality of life throughout that process is the idea of palliative care. And so it was something that's kind of been said in a talk that I had the chance to go to at the AAPA conference, which was by a palliative care PA, was that we hope that we can start to refer patients to palliative care when they get the diagnosis of a chronic disease. So when they have the diagnosis of congestive heart failure, long before they're maybe feeling the full effects and having a lot of the symptoms, because the goal is that you build the relationship with the patient, and the palliative care specialist does, so that they're able to sit down and say, what do you want your life to look like for this extended period of time? And then eventually start to ease into those discussions of like how we want our death to look like as well.
I imagine that unless that's phrased carefully, that might be off-putting to some patients.
Yeah.
Who are like, okay, I have congestive heart failure, but I didn't realize that, I already need to start thinking about this. Although maybe that's not the case. I don't know.
No, she definitely mentioned, which I thought this was really funny. She said, like, I'll come in the room and people are like, oh my God, you're the dying lady. I'm not dying. Like, you need to get out of here. And she's like, no, like, I'm not here to talk about you dying. You're not dying. Like, I'm here to talk about how you want to live. And I think that that's something where it's like palliative care. Yes, it intersects with hospice, but hospice is separate and different, and you have to have a terminal diagnosis, meaning that you have, I think it's 6 months or left to live, to qualify to start hospice care. And so palliative care is separate and comes along before that. And I think she kind of said the way she approaches it is like, I'm not here to talk about you dying. Like that's not what I'm here for. I'm here to talk about how you want your life to look like and what quality of life looks like for you, which I think helps ease that conversation at times, because it is a very uncomfortable topic, I think, for a lot of people.
I do think one thing that Chloe touched on was the discussion about cost. I think that's something that comes up quite a bit. And one interesting way to kind of think about this is, while I don't have the numbers in front of me, we learned this in one of our lectures, and a significant amount of our healthcare expenditures are used or spent on a very minority fraction of actual patients, right? So very few patients are significantly contributing to the overall cost of healthcare. And part of that is because people aren't really having conversations about how they want to die and how they want their end-of-life care to look like. And so then when we don't have these conversations and we don't know what people's expectations are, when they present to the hospital with a COPD exacerbation and all these other comorbidities, we're going to do the whole gamut of treatments, and we're going to try everything that we possibly can, and all of those extra tests and all those extra things that maybe the patient doesn't even want to do, but they're not able to speak because they have declined into such a state, then that really drives up a lot of the costs.
Yeah, so the default position of medicine, keeping people alive, actually costs society quite a bit when that might not be what people want.
Exactly.
Okay.
And I think the idea of like, is keeping someone alive always the best and like doing the least harm for them? And that gets really complex and gets into a lot of like philosophy and ethics. But I think at the end of the day, the best way to approach that is to ask the patient what it looks like for them. And there was a story too that this same PA told where she had a patient who had cancer, and it was somewhere in like the head and neck region. So they were like with HENT, and they wanted to put in like a trach or a Larry tube because of the cancer. And I think
It's a Larry tube.
it's like laryngeal.
Oh, okay.
So yeah, tracheal or laryngeal, basically like ostomy tube. And so I think that was what they wanted to implement. And also basically they were going to have some sort of like parenteral feeding, so that where it would be like through IV or like just like they're not eating food and putting food in their mouth. And this guy was just like, no, I won't do it. I don't want to do that. And the doctors were like, we're so upset. He's not listening to us, and this is what he needs to do, and he's not going to get better if he doesn't. And she was like, well, did you ask him why? And they were like, no. And she was like, you haven't asked your patient why, like what his values are and why he doesn't want to have this tube put in. And they were like, well, no, we didn't think about that. So she goes and talks to the patient. The patient's like, well, I'm a chef, and like I don't know what my life is and like what the value of my life is almost if I'm not able to like eat good food. Like that is so important to me, and it's like one of the highest priorities for me in terms of my life being a good life. And so they ended up kind of making this plan where it was like, okay, we'll go through with this treatment, we'll do this kind of feeding for some time, but if we hit this point and it's not working, and then we'll kind of transition. And he ended up kind of going into hospice eventually because of making those decisions himself and being able to kind of eat food for the purpose of like the flavor and the taste at the end of his life. And that was what was most important to him. So I think we can get so caught up in trying to like save someone's life that we're forgetting that like what kind of quality of life are we leaving them with.
Speaking of Larry tubes, I have a interjection question for you guys. If you had the choice to have a tube placed into your stomach and it's perfectly cosmetic, you can't see it,
Okay.
and there's no cost to you to put the food into the tube, and you receive the perfect, adequate amount of nutrition through this tube, would you get it surgically implanted if it means that you never have to actually eat or cook meals or anything like that again?
No.
Say more about that.
I know, yeah. Short answer, no. I think that food is one of those things, it's a really big part of community and gathering, and it's huge part of people's social lives. So unless it was like medically necessary, like then I'd be like, sure, why not? Because I'm not a chef. I think that if I could never, like, it's almost Thanksgiving. Like you can't eat Thanksgiving. You're just watching everybody else partake in it. It's like we're having a Friendsgiving tonight. It's like, what am I going to bring? Like, I don't need food.
What if you had the option to put turkey into the tube? Like you can manually
That
put
would
it in there.
If that was possible, that sounds terrifying to like watch. So I think I would just stick with formula.
Yeah, pass the syringe.
Yeah.
Pass the syringe of turkey.
I'm going to go blend that up quick, guys.
No,
Yeah.
food tastes too good.
I'm curious what our M1 friend would have to say.
Oh, come on, tacos? Come on now. So that's actually, so my family, as like a tangent off of the tangent, my family does tacos for Thanksgiving. So like I'm not really a big like turkey guy,
Love
right?
that.
So we do ground turkey tacos.
Oh.
And me and a few M1s are going out to Denver for Thanksgiving this year. So we're going to be doing a turkey taco Thanksgiving.
Love
in
that.
Denver,
That's
which
fun.
is going to be a lot of fun.
I love that.
So, but no, I think food tastes too good. And I think that if I can't taste the sandwich that I'm making, that I'm going to have a lot tougher time finding enjoyment in those things.
I admire your responses, and I'm thinking about old college classmate of mine, a dear friend who I will not name, who answered in the affirmative to this question that he would have the tube placed because he could become so much more efficient.
So this is not unheard of. Like there has been this movement. It was big in the 2010s, I remember, where people were like, especially tech bros, were like, I'm only gonna drink this meal replacement thing, because it's so much more efficient and it's got exactly what the body needs, and transhumanism. I don't know, like crazy stuff like that.
Taking that a step.
I shouldn't say crazy stuff. Whatever. Right. I don't want to yuck your yum, tech bros, but it is interesting that a certain segment of society might be interested in doing that. I mean, my first thought was, if I could have abs, that would be awesome.
But like, what is a life of abs without tacos? I just don't know if I want to make that trade. And
well, I think it's interesting that the default position doesn't seem to be to ask the patient like what they want. That's such an interesting.
Which I don't know if that's to say that those doctors were like, oh, I am just not going to ask the patient.
No, they weren't doing it on purpose.
Definitely. Like, I don't think there's.
It's a product of their training and maybe even society's influence on our understanding of what death means and what it means to be ill and all that kind of stuff.
And I think also wanting, as a provider, being like, I want to make sure I did everything I could.
Yeah.
But then it's like recognizing that sometimes what is best potentially for the patient isn't what you would want, or isn't like doing everything possible in terms of life-sustaining measures. And that's like a very tough pill to swallow sometimes.
I think some docs are just uncomfortable with the idea of what they might perceive as like giving up on the patient. You know what I mean? So
or powerlessness.
Or powerlessness. I think a pretty good example of this is when I was working in Denver. And we were picking up out of this like freestanding ER in Denver, and woman with like pretty severe respiratory, a lot of other things going on. Long story short, not breathing very well, right? And so they were like, well, we could intubate, right here. And they were like, well, that's not ideal. We need to get her to a place where we can intubate, in a safer manner, basically. Her blood pressure was kind of marginal, so they were like, if we try to tube her here, there's a pretty good chance she codes, and there's a pretty good chance she doesn't come out of that code, right? Cardiac arrest, sorry, I use a lot of jargon sometimes. And we get to the ICU, and the woman was essentially like the whole time I was listening to the nurse and the medic be like counseling this patient, right? Like trying to evaluate her desire for a breathing tube. And she, wasn't super into the idea without being able to call her husband first. We get to the ICU. Things are worse now, right? She's still, like conscious, alert, oriented, right? And the ICU doc comes in and immediately is just like going for the tube, right? And she's like, can I call my husband first? And this doc is like, no, we got to go right now. And they put her under and tubed her. And we didn't stay to watch the tube. They had some other stuff that was going on. But I think it's one of those cases where like the natural setting, the fundamental setting of a doc, especially in like an ICU or emergency setting, is not necessarily of that palliative realm. It's of the, we want to make this person better realm, even though that's not always an option. And I think that a lot of people in those settings, especially in the ER where palliative is just not something that really exists on a regular basis, to be very uncomfortable with that entire concept, or maybe just being, a little bit scared of that type of medicine when what they're used to is, trying to fix whatever underlying pathology is causing that patient to be sick in the moment.
Also, I wonder if there's just a concern that if we don't take care of this right now, we can't have that conversation later. Like then it will be too late.
Yeah.
To have any sort of conversation. They'll already be gone and we won't know what they wanted. I don't know if that's part of it too, but I could see it.
Well, but I think, I don't even know, I guess what I want to say there, but like, I guess like the idea that it's also just like, I don't know if it's like we won't be able to have that conversation, or if it's just like the liability as well is like an aspect, like, did I do what was expected of me as a provider if I allow this patient? And do we have the foresight to have the discussions of like, am I allowed to give them that autonomy? Am I supposed to? Like, I think, again, we have that medical training of, well, I know what I'm supposed to do medically, but what about like ethically? And like, I think we try to have those discussions. We have ethics sessions, but there's only so many scenarios that you can like talk through in like an hour-long session. So if
I could just add something here, I also feel like there is at least moral distress and possibly moral injury to the provider, where you have someone who, especially if the family is prolonging the patient's life, when the physician maybe thinks that it might be best to give this patient, a good death, a comfortable death, right? And there's a lot of discomfort in that, where you are, caring for these patients, there's, very little or no chance that they're going to get better. And you are just, for us, it was taking these patients to the ER over and over and over again with the same issues, in the same ventilator, without improvement, maybe even getting worse since we last saw them. And having to do that on a, week-to-week basis has a real chance of, like, hurting the provider who wants to do the right thing and wants to make this patient comfortable, whereas, the family who's maybe not ready to let go is, asking for that full court press. In American medicine, we're very good. If someone wants a full court press, we'll do it, but is that always the best thing? I don't know.
And I think it's interesting, every time we have these conversations, we talk about what's best for the patient, or like what the best outcome is. And this always brings me back to, like, what frame of reference are we using to determine what best is? Because I think we all kind of have this standard frame in our heads of what health is, this picture of health, right? And that's what medicine is trying to strive towards. So that's our default.
I'll cut the camera to me for this part. That's what health.
In the embodiment of
Yes.
health.
Yes. Thank you.
And I just think it's interesting because even like for all of our listeners out there who are hoping to one day get into medical school, at the University of Iowa, at least, and other schools as well, if you interview, they ask you an ethical question. And one of the things that they're looking for, and that at least what I'm told by the admissions people that I talk with, are you able to display professionalism, right? Or that's one of the aspects of the questions like that. And one of the classic questions is a Jehovah's Witness who refuses a blood transfusion, right? In our perception of educated, soon-to-be doctors, the best decision for the patient right there is to do the blood transfusion. But if you answer that in the interview question, that's going to be a dock on your ethical understanding of different, cultures and religions and patients. And so it's such an interesting balance, because on the one hand, I think we have this idea of what health looks like, and then we just don't really talk about or incorporate what the patient's best health is looking like for them. And so it's such a fine line between balancing like this relativistic approach to health and just, not pursuing what is objectively and scientifically shown to be effective treatment, while also, walking that line.
It feels like it violates the human need for cut and dried ideas.
Right.
Well, and I think like there's a very good, we talked about, interestingly, during orientation with the students, because having a discussion about wellness, and like before the M1s and PA1s are getting into this very like challenging clinical courses, how are you going to like maintain wellness, and talked about some different ideas of health. And a lot of those are kind of pulled from like Native American like cultural ideas. They're pulled from different cultures. I think partially because like in our maybe very like Western paradigm, we don't always include some of these other aspects, but there's kind of like one of my favorites, I think, being like almost like a pie that's like sliced into like slices of pie, and there being like spirituality, like physical health, mental health, emotional health, like all these different aspects. But then also the idea that sometimes one of those might be out of sync, and sometimes, something else takes over and fills up that portion, and that it is kind of like shifting throughout your lifetime. Sometimes you might have a greater need for like spiritual health in a certain part of your life, and then other times physical health is more the focus. But again, it's very gray. It's not this idea of just like, well, you need like this much of each thing and we can like fill that out perfectly.
And it changes over time. It changes with your circumstance. I want to return to something you said, Jonah. You said the phrase good death. And I want to know more about what you guys think about that phrase. Like, what does that mean to you guys?
I can start off, since I guess that was my comment. And I mean, okay, it very much can depend on your background. For me, at least, it's mostly based on my experience that comes before medical school, right? And that's like working in ERs, working with a critical care transport team, right? Working in EMS. And in those cases, when I think of a good death, I think of one that is without the trauma and the suffering that can be involved, right? I think of one without pain. I think of one without suffering. And I think, at least in my experience, where that comes from is doing CPR on, patients with their family watching. Everyone is crying. I'm on the borderline, I'm borderline crying. And basically being in that moment where you see the suffering, maybe you get a heart rate back, but you know that there's going to be no meaningful chance of recovery, right? And so at least that's where I come from, is seeing the suffering that can occur in these emergencies and wanting desperately to avoid that for as many people as possible, or at least having the conversation for them to be able to express their wishes to not want that, right? Because not everyone wants that done to them. And so at least giving people the opportunity to be able to discuss that before it comes to that point. Because just to say one more thing here, that I think we all consider death as an abstract concept until it becomes incredibly real. A patient's family might be okay with, a patient saying, hey, I don't want to do, if I go, don't resuscitate me, right? Do not do CPR, do not put a breathing tube in. And everyone's cool with that concept until it becomes real. And then the moment's there. And then EMS is looking at you and saying, what do you want us to do? Or the doc is looking at you saying, what do you want us to do? I want to honor their wishes. And a patient's family just has the abstract concept has become incredibly real for them. And so having these conversations as much as we can beforehand, which is really why I think I signed up for this episode, despite having very little background knowledge in terms of palliative care, I just think that's so important. It's something that we could be doing better for our patients, is getting palliative care involved so much more, basically earlier and more often than I think we do currently.
I mean, good death, I think we also have to decide what death means. And that's also, like you were saying, it's in the gray. And I think that's super true. So I, in undergrad, was like an at-home CNA and a hospital CNA. But when I was in the home, like I did hospice care and just normal cares, working with mostly like elderly folks. And like the meaning of death to people is so drastically different. Like some people are like, death is just the end. We're atoms. It's poof, gone. So I just don't want to suffer. Like I don't. And then some people are like way more worried about like death to them is way more worried about like, what am I going to pass on to my family? Did I teach them all the lessons that I want to? Things like that. Or it's like, if different religions, death means different things. And you also, I think, as a physician, have to decide what it means to you, because it is going to put you at some sort of bias. So like for me, I'm a Christian, so I believe that Jesus Christ has saved me from my sins, and when I die, I'm going to go to heaven. So I don't fear death. I fear suffering, but I don't fear the actual death. Because, yeah, no one wants to just be, like, suffering for forever and ever. Like, that sucks.
Yeah.
But, so, like, I don't fear death itself. And so when I'm talking to people or I'm caring for people, I'm coming at it with that perspective very much so. And if I'm dealing with a patient who has the same values as me, we're like in sync, I can understand them a lot better. But then when I'm dealing with someone of a different culture, different religion, it's like there's automatically like a disconnect between me not fearing death, wanting to prevent suffering, and them fearing death because death is the end. And that's just a very different perspective that like they don't understand my perspective. I don't understand their perspective. And it's going to put me at a bias for how I want to care for them. Because mine is very much like, I think palliative care is super important. Like my whole family, like we've watched multiple grandparents go through like the whole palliative care, then hospice care. And it's super hard, like to go through. Like my grandma's on hospice care right now, but like she's had 6 months to live for the past like 2 or 3 years, like almost died several times. Like the woman's had COVID, the woman's had a stroke, she's had medication mishaps in the hospital, and she's like, God's keeping me around.
This is one of these really interesting things about our idea, even our scientific understanding of death, which is, I think, lacking in a lot of ways. Like we're still finding out that death is not a line, but a process, right? I was reading some article earlier this week about a third state of life, where, after we as doctors would say this person has died. There's a lot of interesting activity that happens after that point, Cells are doing things that they didn't do before that point. They're organizing in different ways than they were before. I just think that's kind of an interesting thing to think about. I don't know if that it has any practical application for I don't think anybody knows yet whether that has any practical application for preventing death or preventing anything. But it seems to indicate that there's more to it than we think about usually.
I think there's also something to it where physicians, or really anyone alive, has no idea what death is really like, right? And so it's the one thing, like if you say, hey, I want to give you this medication, I want to prescribe this for you. You can say, hey, here are the side effects. This is what might happen, right? This is what it's going to do to your blood pressure. This is, how it's going to affect your life. When someone, in the palliative realm says like, hey, we're all going to die, but like, hey, you have something that will kill you. And for us to say, we don't know what that's going to be like for you. That's a terrifying
That's
thought.
hard, yeah.
That's hard. We're in medical school and PA school, right? Like we think that we are going to be able to learn these things to be able to talk to our patients about it, but we have no idea. And we're just trying to care for people as best we can with the limited information that we have, right?
It's
That's
also
hard.
like they can train us however much they want to like practice having like information sharing and talking to patients about death. I mean, like when you hit your like Medicare age, then you have to start filling out your DNR. Like, do you want a tube down your throat? Do you want CPR? You have to start doing that because it's legally required of you. But like every patient is so different that they can give you all the practice ever in medical school, all of the simulated patients that we want that are going to follow a script. And it's just not going to be like the real thing until you're actually with that individual patient with those individual values.
Well, we're going to continue the discussion in the next part of our show. But if you have something you want to say, shortcoats about today's show, about our discussion, question you have, go to theshortcoat.com/tell us and send us a message. Otherwise, until next time, I'm Dave Etler saying don't let the bastards get you down. Say bye, everybody.
Bye.
Bye.